feel free to just pick back up whenever you ladies are ready.
Okay, so I thought it would be beneficial, just to illustrate really quickly, Mr. Hidalgo, to your point, there are other things that we have in our presentation today. This is a full summary of all of the topics that we're going to talk about, and an estimated of savings. We're looking at the second line item on here right now that's yielding that 1.8 for your fiscal year. It's 927. So there are a lot of other things to consider, but this is one of them. The other couple things that I wanted to mention is that when we talk about Tier 1 and Tier 2 from a deductible and an out-of-pocket maximum, those deductibles and out-of-pockets are integrated, which means that you do not have a separate deductible for Tier 1 versus Tier 2. So an example would be a member meets their out-of-pocket maximum in a Tier 1 provider of $1,200 and then goes to a Tier 2 provider. They would only have an additional $200 to meet with that Tier 2 provider, okay? So deductibles and out-of-pockets are integrated. There was a couple questions as well regarding network. Anybody can go online to Blue Cross Blue Shield's website, and when you search for a provider, if you choose the EPO network, it will provide you a list of all of those providers that are participating, if anybody wants to look at that.
Make sure that when you select EPO, you then select Blue Connect, and that's going to show you for this particular model, those providers that are in that network.
All right. So the next plan design that I just want to cover really quickly is just your out-of-network benefits. So your out-of-network benefits today mirror your in-network member benefits, meaning the deductibles and the out-of-pockets are very similar to that members pay when they go inside of the Blue Cross network. It is very difficult to go outside of a Blue Cross network, which is probably one of the reasons why the district has chosen to partner with Blue Cross, because the access to care that your members have, not only here locally, but nationwide. We would recommend that you change your out-of-network benefits to get more in line with what the market has. When members just choose to go outside of the network, they would have substantial cost sharing there. Of course, if it is an emergency situation, so anything life or limb threatening, they're going to be treated as in-network. So this would only apply for those members that are choosing to go outside of the national Blue Cross network. We did an analysis there and pulled all of your claims from September of 23 through August of 24. The below chart just represents how much is hitting the plan outside of the network. That is about $1.2 million. So, a pretty small amount that is going outside the network, but we would recommend for all three plans to have a change in the out-of-network benefits. Any questions with the high performance network? All right. So the next topic we want to cover is your retiree population, your Medicare Advantage renewal, and your post-65 retiree options that you can consider. The first thing that I just want to touch on, and we mentioned it earlier, is just the impact to the Inflation Reduction Act, right? The Inflation Reduction Act was passed several years ago. Every year there seems to be an impact. This year, bigger than any other year due to the changes with IRA. It's important to note that these changes are driven by Medicare, right? They want the member to not have large out-of-pocket expenses. So these changes are all positive impacts to all of your retirees in the Medicare space. Unfortunately, they do have impacts to the payers, right? So you as a self-funded plan or in your Medicare Advantage plan, Humana has an impact as well, right? So just as a recap, we've eliminated the coverage gap phase. So there was a donut hole that has been closed. This year, the big change was the elimination of just adding a $2,000 annual maximum out of pocket. So it's a spending cap on prescription drugs that retirees would have. There's also a option for retirees to enroll in what we call the MP3 program or M3P program. It basically has them the option to spread out their out-of-pocket prescription costs, kind of like a loan, right? So they're not having to come out of pocket large amounts at one time. The out-of-pocket insulin prices were capped at $35. That is going to continue to 2025. And then there was an expansion of adult vaccines that also occurred in 2025. In addition to that, there were several changes with CMS funding, right? And this significantly impacts your Medicare Advantage plan, mostly, because the funding of that plan is coming from two sources. It's coming from the premiums that the district pays to Humana for the Medicare Advantage plan, but it's also coming from CMS. CMS is heavily subsidizing and sending money to the insurers to pay for the claims of your retirees in that Medicare Advantage plan. So these changes here have impacted the funding that the insurers are receiving. So when we talk about options for the post-65 retiree folks, we're going to hit on 4 of them today. The first option is an automatic enrollment of the Humana Medicare plan for all Medicare eligible retirees that have Medicare Part A and B. In this option, members will have the opportunity to enroll back in the commercial plan in year 2. Option number 2 is an automatic enrollment to Blue Cross Blue Shield of Louisiana's Medicare Advantage plan for all Medicare eligible retirees with Part A and B. As mentioned before, members will have the option or the opportunity to return to the commercial plan in year 2. The third option that we're going to talk about today is Medicare eligible retirees with Part A and B who are currently on the Blue Cross Blue Shield plan. They will no longer receive a discounted premium for having Parts A and B. So your members, your retirees today that do not have Part A and B actually pay a higher premium than those with A and B. So this option would remove the discounted premium for those members. Option number 4 would be that all new hires starting January 1st of 2025, once they retire and become Medicare eligible, they will be required to get Parts A and B, and it will be mandatory for them to move to the Medicare Advantage plan.
I have a
All right.
question really
Yeah.
quick,
Mhm.
and maybe you'll get to this later. Do we have any requirement for how long someone has worked with us and then they retire with us and then receive all the benefits? Does LPSS have that? I don't think we do, but I just.
Ms. Mason, sounds like you're addressing vesting.
Yes, sorry.
That's a long answer that we can probably deep dive into, but the quick response to it is no, there's not currently a vesting policy with LPSS. I'll give you an example. Let's just say I'm coming from St. Landry Parish. I'm nearing my retirement. 2 years later, now that I've been with LPSS, I retire from the district, retire from here. It's whatever benefits I have on my payroll at the time of retirement, I am eligible to take with me. That would include your Blue Cross and any of your voluntary benefits as long as it's applicable post-retirement. So the answer right now is no. District and administration is aware of it. That's a lengthier conversation that we can certainly address. It is a concern because there is no vesting criteria, and essentially the member can leave with our group health insurance in particular, which is what we're focusing on, to include their dependents for their entirety of their life. They can take it with them.
Ms.
Thank you.
Mason,
Yes.
first let me apologize to Ms. LaBeouf because I know you're not going to like my comment. In 2017, the school board did address vesting. However, it was too antiquated of a policy for the school board to put into place. Now, I'm disappointed about that because it should have immediately come back to be cleaned up, but I don't think that we were structured then, and possibly we're not structured now for that particular vesting schedule that was adopted by the board. But I have asked Ms. LaBeouf to have this on one of our committee meetings very soon, maybe next month, who knows, to talk about and start a conversation about, because it's, in today's day and age, with what we're dealing with, it's not right. It's not right. We have to address it. So, did I misspeak at all, Ms. LaBeouf?
I think Ms. Gardner has some input too.
Okay.
No, we, Ms. LaBeouf and I, when we began working through insurance in almost 21, the fall of 20 to 21 is late spring when we discovered that the vesting policy had not been put into play when it was adopted. And by that point, we had thousands of retirees and things, or people who had left the system that the vesting policy had not been implemented for. So to be able to backtrack and retrack and implement that with all the codes, it was an impossibility at that point.
To be clear, I was not suggesting it had anything to do with this administration. Yeah.
All right. So the next couple of slides are just going to illustrate the removal of the Medicare discount. We put this first because it's probably the easiest one to explain. It is just a premium change to the retirees. So what you'll see here is the proposed 2025 premiums that align with the retirees who do not have Medicare Part A and B. They would pay the same amount as retirees that have Part A and B. And you can see that all the way to the right is going to be the differential in monthly premiums by aligning those retirees' cost share. The top part is the basic plan. The bottom is the enhanced PPO. Okay. Question?
Let's look at the highest subscribers. I guess that's the 918.
Yep.
Run through that scenario.
Sure. So I'll start with the basic plan. You'll see kind of in the middle of that box, BM retiree only with Medicare Part A and B. There's 918 retirees enrolled in that plan today. The rate would go to $190. That is a $80 a month change to $80 per month change to that rate.
If you press Control Plus, I think it might make it bigger for
Oh,
people to see.
perfect. All right, thank you. Thank you. But again, we're aligning that with the first line where you have 314 retiree only. Those folks do not have Part A and B, and they're paying $190.
Can you repeat that? Can you repeat that and explain that?
Yes, so for retirees that do not have Part A and B coverage, currently they are paying $190 for single coverage.
And what does a retiree with A and B pay?
It's
110.
yeah.
Medicare A and B member currently is paying $110. That's why you see that $80 increase. It would bring them to the $190 total in that example. Key factor to remember here, remember how we've had other discussions at other board insurance committee meetings that have discussed how members still under Medicare are still using doctors in not using Medicare primary doctors. So we are incurring claims and billing as a result of it. We've talked about that number before, if I'm remembering correct. Weren't we looking at a $2.4 million number? We haven't reassessed it recently. That number could have increased since that time. But the reason why we looked at this, again, because we did discuss something similar. We discussed this was an option during the budget process as well. I don't know if it landed at your doorstep. If I'm trying to remember, we built out 8 different budgets. This was one, but that was the primary driver with regard to those discussions, because some members were still using Blue Cross Primary even though they had Medicare, yet they were receiving a discounted premium. That could have been the member under the BM, which is a retiree-only Medicare A and B. So that's why we asked Gallagher to take a look at the premiums and remove the discount to see about the cost savings associated with it.
To add those premiums, though, prior to removing the discounts, are stated on page 10 of the presentation. And we can move it. So you'll see where there was 110 as opposed to 190 for the Medicare, retiree only with Medicare A and B. We did just show the dollar differential here on this particular slide, so it does give the monthly differential.
And I do want to just point out, just call out that, remember that these folks do have an option. I mean, currently they can go, those folks with A and B can go to the Humana Advantage plan.
Yes.
Just to bring that
We're just gonna,
all together.
let's give it a second. I want to make sure that Mr. Lejeune gets his questions answered before we go further.
Yeah, you can go ahead. I got it.
Got it?
Ms. Jennifer, she clarified everything for me.
Thank you. Okay. We're on 28, but page 10 is kind of, I guess it's hard to put all that
Yes.
on one sheet.
That's why we didn't.
Yeah, but page 10 shows the current situation. But I mean, we're not going to go through every one of them. We just gave an example of one category.
Yeah, and I just want to point out that the savings to the district to make this change on an annual basis is $2.7 million. In your fiscal year for 6 months, it would create 1.3 million in savings. Yes. Yes, on an annual basis.
That's correct.
How do I zoom back out? Hit next? Yeah, next. Okay. Okay. Any other questions? All right. So slide 29, we're going to go through a couple other scenarios as it relates to an automatic enrollment option into a Medicare Advantage plan. I just want to make some comments about the Medicare Advantage plan. You know, the cost of coverage and the cost of services continue to go up everywhere. You know, the board approved deductible increases, maybe considering some out-of-pocket increases. So the retirees that are on your commercial plan continue to see increases, you know, with their member out-of-pocket costs underneath the commercial plan. CMS, though, has a different agenda, right? They are looking to reduce costs for your retirees by proposing changes in these Medicare Advantage plans. So just keep in mind when we talk about the plan designs for the Medicare Advantage plans, the members' cost shares are a lot less out of pocket than they are underneath the commercial plan. So a very enhanced benefit because the plan designs are They are designed for that population that is no longer receiving an income and has, little income to spread around. Yeah, and really, the goal of it is driven by CMS. I mean, CMS is putting a lot of emphasis on Medicare Advantage plans, right? They're heavily subsidizing the plans. Like I mentioned earlier, premium that you're paying to Humana plus what CMS is providing helps support the plan. So it is an initiative that is coming down by our federal government to push people to the Medicare Advantage plans because we feel like, and they feel like, they're going to be taken care of better in those plans, right? That their members' out-of-pocket costs are going to be a lot less than they would on the commercial side.
What I think she means by that is that, again, these premiums are being subsidized by CMS. So it's not that the claims and the premium does not support those claims. What supports those claims is what's provided by CMS. And your self-funded plan isn't receiving that subsidy money on the medical. It is receiving some subsidy money, through the Silver Scripts plan.
Right. So we're talking about the financial impact. We're talking about, how it's being subsidized financially. But let's talk about it from a provider standpoint, a medical standpoint. This is my doctor. This is my hospital. This is my provider. Let's talk about it from that standpoint. We've heard for years and no disrespect, but we've heard for years and years and years that it is a tremendous amount of difference financially. But let's talk about it from a medical standpoint.
Yeah, so from a medical standpoint, many of the plans are what we call passive PPO plans, which mean that, members can go to providers as long as they are accepting Medicare, right? So although there is a network that is utilized, if a provider is accepting Medicare, then the plan would pay for that provider. And those regulations, that is regulated by CMS, not the insurers. So that's one thing to note. Members will have full access to, all of the providers that they're using today. Now, Mr. Hidalgo, there are some providers that are just challenging, right? So we know of some that choose not to participate in any network, right? Some that don't participate with United Healthcare or Blue Cross in general, and basically, tell the member that they're not going to see them. But the plan is set up in a way where the plan would pay as long as the provider sees them, then they will be covered underneath that plan.
So whether it's Blue Cross or not, right? So my concern is that we've heard time and time again, and I don't know if the hard evidence has been brought, but we've heard it seriously from folks that, I don't want this because my doctor's not going to accept this. So then my question becomes, are you Medicare eligible? And if the answer is yes, then my next question is, so are you then going to a non-Medicare doctor? You're Medicare eligible. That should be your primary. Are you using Blue Cross as your primary when you're supposed to be using Medicare? And then many times the conversation doesn't, get past that point. Sure. I don't know about the rest of the board members, I am not concerned about that demographic because that is not the way our plan is set up to be able to function and be solvent. So that particular demographic, and there's $2.4 million worth of it happening right now in the district, well, last year. But I want to be sure that for everyone else who is abiding by the plan and attempting to keep our plan solvent, that any potential change is not going to negatively affect them so far as to say nobody's going to have to change their doctor. If someone is Medicare eligible and they're not using Medicare because their doctor doesn't accept it and they're just saying, here's my card, then they're going to have to make a change or pay for it.
Yes.
Because our plan is not set up to accommodate that. But if But otherwise, I want to make sure that no one is going to be negatively affected by a provider, hospital, doctor, etc.
You want to answer that?
I think what you're saying is, I think there's always confusion around Medicare Advantage plans. I really do. One, I think that folks get confused by Medicare Advantage plans from the individual market versus the group market. They are not one and the same at all. So you cannot compare a group Medicare Advantage plan, regardless of whether that Advantage plan is with Blue Cross, United, Joe Blow, it doesn't matter. They're not one and the same. They're not filed the same way, and they don't function the same way. So I think that's the first confusion. The second item, I think where you're getting at is of course these Advantage plans have networks tied to them because it's in the title of their program. We've got a Blue Cross Medicare Advantage plan. We've got a United Medicare Advantage plan, or what you currently have, a Humana Medicare Advantage plan. And there's always, of course, Louisiana and our market, we tend to get and feel the warm and fuzzy from the blue, right? And so it scares all of us when we hear other networks outside of what we're comfortable with. I think what we're trying to explain is that these group Medicare Advantage plans, the requirement is that as long as you are seeing a provider that accepts Medicare, they should, and we run through hiccups, what we do run through, and I want to be completely transparent, is educating the person sitting at the front desk of that provider's office. But I haven't run into a single situation with, regardless if my client is with Humana or Blue Cross, where we can't re-educate the person that's sitting at that front desk, taking that insurance card, and processing the claim accurately and without issue. So it doesn't matter unless you have a provider that says, I'm not accepting Medicare. And I hope
So,
that.
to expound, if someone sitting at that desk sees a Humana card and assumes that it's a private plan,
Correct.
then they may say we don't accept Humana. When in fact, they accept Medicare, so they do accept Humana or Blue Cross. I don't care if it's Humana, but
Yeah.
Medicare Advantage. We need to
Right.
stop saying company names because that's been the whole hiccup, and that's been the whole politics behind this the whole time. Forget about what company it is. It doesn't matter. If it's a group Medicare Advantage plan and that provider accepts Medicare, they shall accept that benefit.
Absolutely. And it's an education problem. And that means that Humana, with their white glove service that you pay for, that is required by them, by CMS, they then re-educate the person at that front desk, and we get that issue solved. And you don't see it happen, Mr. Hidalgo, very often. I think it's a scare tactic that we feel and see, but you don't actually have that happen. It's less than 1% that happens in the state of Louisiana. And I'm going to.
May I ask a question, please? Yes. Okay, so could you educate me, because I get a lot of this. I am a retiree within the parish. Worked with them, live amongst the community with them. Tell me the difference. Educate me so I can educate them. What is the difference between Medicare A and B and Medicare Advantage? Because that always seems to be the issue.
You want me to take that? Okay.
With that, if y'all can explain, to piggyback to his question, the board members get a lot, they're taking away my Medicare. That's the question that they get. So I wanted to give that to you so you could give them the full response of, am I right, Mr. Lejeune? That's the question you get. Okay.
Yeah, absolutely. So the way I try to explain this in an easy fashion for someone to understand is, first off, in order to get the Medicare Advantage program, you have to have Part A and B. But what it does is the Medicare Advantage carriers have already coordinated with CMS on the front end to pull it under the plan. So you're still going to walk around with your Medicare card that shows that you have Part A and B, but it just makes life easier for you. And instead of presenting that Medicare card, you're just presenting an ID card that says Humana on it. which has already, anytime we enroll someone in a Medicare Advantage product, we have to get their Medicare Part A and Part B number, which then has to be verified by CMS before they create an ID card for your retirees and send it out in the mail. So it's coordinated with CMS, the Medicare Part A and B on the front end, and then they receive one ID card. They can always keep their Medicare card in their pocket, and that's where they would use it with any provider that accepts Medicare. I hope that helps explain.
Yeah, today they have to give 2 cards, right? They're given their Medicare card and their Blue Cross card.
If this is instituted, and in the second year, someone wants to come back to the old plan, do they still have Medicare Part A and B?
Yes.
You don't lose it.
Yeah, you don't,
It's almost like you've relinquished that to this entity. It's almost like for that period of time in which you've gone to Medicare Advantage, you've relinquished using that A and B card, and now you're utilizing that Humana card, that People's Health card, that Blue Cross card. And what's embedded in some of these Advantage plans is they have to have equal to or better benefits than A and B. And so some of them have wellness plans, some of them have dental benefits, some of them have vision benefits. Just as a little sidebar, I'm going to jump ahead.
So let me,
wait, Mel.
Okay.
let me ask you this question, because you have it referenced at different places. So here's Humana, and here's Blue Cross. Tell me the difference between, like, for example, Blue Cross Med Advantage. What's the difference between the two?
Mr. Touchette, you mean comparing Blue Cross Medicare Advantage and Humana Medicare Advantage?
So each plan has to meet the requirements of CMS. They have to have these basic elements of benefits that follow Medicare Part A and B.
What's the difference?
But we have a chart that can show the difference. I was just trying to kind of give a broad understanding, but we do have the differences.
So I think you addressed 2 of these, but let me just go through them. These are questions from the retirees. Can a retiree buy their own plan without being subject to Medicare underwriting? How about we stop there? You want to try that one?
Yeah. Okay. So repeat it one more time, because there are specifics and I want to make sure.
Can a
I'm addressing-
retiree buy their own plan without being subject to Medicare underwriting?
medical underwriting.
Medical underwriting, yes.
Okay. So if you are a retiree and you have Medicare Part A and B, you can, from the time that the group plan terminates, whether that retiree is enrolled with the Blue Cross commercial plan or even currently enrolled in the Medicare Advantage plan, that retiree has 63 days to go out and get an individual plan in the market without being medically underwritten. 63 days, yes.
I'll let you walk through these. How about that? And I'll let Kim have a seat. Let me know if you need me.
Okay. Okay, says, please explain the difference between group advantage versus individual advantage plans. The disadvantages of individual plans do not globally apply to our group plan. Yeah, so I did address this slightly. A group advantage plan is a passive PPO network. So it's global, it's nationwide. It has different parameters, but it does have to meet, typically it's less costly, right? But it doesn't have as many restrictions as a Medicare Advantage plan does on the individual market. This plan is required to have every element of what CMS requires to be under Medicare Part A and B to be covered. So it's going to have that plus more essential and heightened better benefits. Yep, oh, yes, okay. Since there are doctors who take Medicare, okay, can you read that?
take no advantage.
Okay, since there are doctors who take Medicare but take no advantage plans, won't people be affected and lose their doctor? So, yeah, one, if you know of someone or a provider's office that's not taking, that takes Medicare but not taking this Humana product, then there's an education barrier. There's also a way that a claim can be filed directly with Humana as opposed to the provider filing it, because it's required by CMS that Humana pay the claim. So there's either an education barrier or it's a different advantage product, typically an individual product, out on the market that you're hearing these things from.
So once again, if a provider accepts Medicare, they must accept a group Medicare Advantage plan.
It's a passive PPO they are
Passive
required
PPO, they are required to. So fellow members, what I'm going to ask you to consider is that we cannot police Medicare providers, secretaries, and front office personnel and coding people. If they are not doing something that they're supposed to be doing, that should not have an effect on our decisions. And if someone is doing it, the last time someone came here with a sign, with a picture of a sign that says, "We do not accept Medicare Humana Advantage plans," it did not specify whether it was individual plan or a group. And I asked for that doctor's name, and I was told that they were not going to give me that name. But I say, let's find out who they are, so we can get this. We can make sure that we get the appropriate people to their office to handle this problem.
I think it's important to note, too, that every retiree that you have enrolled currently in the Humana plan since inception, not one person has disenrolled from the plan.
As a matter of fact, the next question next year is going to be, I only have Part A, why can't I join this plan? And the answer is because you haven't been paying for Part B premium.
And that's precisely what at least 10 people have called me about from Vermilion Parish, saying, from Lafayette Parish, who are friends with people in Vermilion Parish, I'm not Medicare eligible. Why can't I get on that plan?
Right.
Okay? And so, again, it's about education.
Agreed.
And I'm gonna just say, it's not so much the plan. I am not in favor of forcing them to get on something they're not comfortable with. If it's a choice and they choose it, I have no issue. But the forcing is the issue that I have in making them do something they're not comfortable with.
Yeah, and so that's why our recommendation is to allow them to come back to the commercial plan if they choose to, and it's not working for them in year one.
But you're forcing them into a year, aren't you?
It's an auto enrollment in year one.
Because a lot can happen in 1 year.
I think, and remember, we're just consultants, so we're not here to sell anything. We're here to try to help balance the budget. And we're here to answer your questions so that you can make decisions. But I try to play devil's advocate sometimes, and that is, you have people that are active employees who don't elect your health plan. And the reason why is because they don't want it. So as a retiree, they have the choice to go out and buy a supplement policy, an individual Medicare policy. You're providing retiree benefits, and you're doing it in a different manner than you did before. The automatic enrollment is really something that has become extremely popular in the last couple of years, and it's because there's not a lot of pushback. Once the folks have moved there, they're happy. There's usually carrots and sticks that get people to kind of nudge them to start participating and start listening to these new products that are available through education like we are today. There's a reason why that Medicare Part A and Part B premium has been recommended to increase, and that's because it creates a bigger spread. So if you have somebody who's paying now $190 versus $0, they have to think a little bit more about it. You typically don't want people coming on and off your plan anytime you want, even the federal government basically says the actives can't do that. You know, they can only do that through qualifying events or one time a year during your open enrollment. So you try to keep it similar with that. So I understand what you're saying about, you know, only forcing them to do it, but what you're doing is you're providing a retiree benefit. You know, it's very unpopular to say, and I know that you're not going to go there, and that is a lot of companies don't offer retiree benefits, and the reason why is because of the cost. CMS understands that. They know that they're going to get those Medicare claims anyway, so now they're subsidizing these companies like United and Blue Cross to offer these programs with subsidy money. I just hope that helps. It's difficult. It's very, very difficult.
Okay. So the next couple pages just go through the financial analysis of the auto enrollment. The first one that you'll see here is the auto enrollment option with Humana. Remember, in year 2, members will have the opportunity to come back to the commercial plan. So after we've calculated all the costs that is paid by the plan, taking back out any kind of subsidies or rebates that we're getting from the Silver Scripts plans, we come up with a $5.9 million savings to the plan if we auto-enrolled. This is based on 2,308 members that currently have Medicare Part A and B.
I want to mention, so this is the automatic enrollment, this is with Humana, and this is with non-comprehensive benefits included. So this does not include a comprehensive dental benefit. There are dental benefits in this one that are required by CMS to be in a plan like this. But you now can add a full dental plan, a full vision plan, and full hearing benefits, which we'll go through that analysis in a moment. Your current Humana plan in place today under the voluntary structure is this plan. So it does not include comprehensive dental, vision, and hearing benefits. So in the next slide, we'll show what Humana's number would look like with those benefits added.
Yeah, so if we made modifications to that Humana plan and we included these comprehensive benefits, like Lana mentioned, dental, vision, and hearing, when we calculate that analysis, obviously there's a little bit of an increase in premium to include those. It would still yield a $5.6 million savings to the district. The next analysis incorporates an auto enrollment option with Blue Cross Blue Shield of Louisiana. Blue Cross, they don't have the option to carve out comprehensive dental, vision, and hearing. All of their plans include comprehensive dental, vision, and hearing. So when we calculate the savings moving to Blue Cross Blue Shield of Louisiana for your Humana Care, your group Medicare Advantage plan, it would yield a $3.4 million savings to the district.
Why is this? Why is it so significant? Why are the differences?
So Blue Cross has not been in the Medicare space as long as Humana and a United. So they're still trying to catch up and develop how to price these programs.
Yeah, and really, a lot of it is driven by the subsidy dollars from CMS. So being that they haven't been in the space for as long as these other carriers, there's a lot of metrics that the other carriers are measured on, controlling the claim cost. So they're likely getting a star rating that is a little bit less than Medicare, than Humana and United, which means they're getting subsidized less. So they are having to charge more in the premium because they're not getting as much funding from CMS.
Is it either or could both be an option?
It's either or.
My only concern, if this even takes it another step further, but my only concern is that you have about 300 currently on our
423.
423 participants in our current plan who have all opted for the plan. They have not been influenced by any, anything. They chose to go. They are not coming back. And now, if we switch to Blue Cross, to have a fuzzy, comfortable name, we are going to be impacting 420 somewhat people who have made the switch and who are comfortable with their current. So it's the same difference. We're making a change. If it moves forward, we're changing, and then we're going to impact people who are on a better plan than the fuzzy name plan.
Yeah.
And it's costing a lot less money. That's my only concern. That's why I asked if it was either or.
Yes, it's either
A-
or.
And real quick, the $3.4 million savings for the Medicare Advantage plan, that is with the removal of the premiums of the retirees that are on the Blue Cross plan. That's still the cost savings. Yes, the 3.4.
The retirees would have no premium if, right,
That is-
so that's with the
That
removal
is correct.
of the
Yes,
premium.
Yes.
that is
Okay.
correct. Yeah, for the retiree only. Yes. So retirees that participate in the Medicare Advantage plan pay $0 for that plan. And that would continue.
So for the example given earlier, whatever the code name was for the $110 that the retiree's paying today for the current plan, if they were on the Medicare Advantage plan, they would pay $0 for that plan. Oh, yeah, well,
Yeah.
of course, they still have to pay
In
Medicare.
addition to paying Part B
Yeah.
for Medicare.
The next couple slides really just goes over the timeline for implementation. If you were to decide to move forward with any of these options, the timeline relatively stays the same. We would have to move pretty quickly. A 90-day implementation is ideal, especially for this population. We know that, we have folks that are potentially in nursing homes, hard to reach, and we want to make sure that we get as much outreach as possible. There's customized letters, FAQs are created. We hold retiree meetings in conjunction with the vendor of choice. There's a lot of communication that has to be done prior so that we can make sure that we connect with as many retirees as possible on the changes and they're able to get their new ID card before January 1st of 2025. The next slide just really talks about the dedicated service support that is going to be provided by any of the vendors, really. So there will be a phone number that all members can call specific for Lafayette Parish School Board. That number is available between 8 and 5 Central Time. There's also a 24/7 emergency line that is also provided. Like I mentioned, we would hold kickoff meetings to help members understand any of the benefit changes in person. We'll have links, videos, mailings, all of those things to go out to make sure that we're communicating appropriately with the retirees.
This next slide just breaks down kind of where your renewal is sitting. Currently, you have 423 members enrolled in the Humana plan. As you can see on the right-hand side under Humana PPO renewal, if you scroll down, none of the benefits are changing for the renewal with the exception of the enhanced $2 out-of-pocket max. Your rate currently is $213.21 per member per month. It's about $1 million, 1.8 or 1.08. With the renewal increase of 229.06, it's 1.1. So it's a 7.43% increase. That is with your current population. If you take a look at Blue Cross to the right-hand side, you'll see where they landed at 352. That's where previously you saw those savings dollars decrease a bit. They do have slightly better benefits from a prescription standpoint. Two things I want to point out. They do have a $1,000 out-of-pocket max with Blue Cross. There's no way they don't have a product that has a $0 out-of-pocket max because they also, and I I apologize, but if you look at the line called emergency room, Blue Cross requires a $50 copay anytime you visit the ER. So those $50 out-of-pocket costs would apply towards that $1,000. So they do have slightly less benefits than your current Humana plan. Yeah.
And just as a note, we did receive, I know we haven't talked about United Healthcare, but we did secure a market bid from them as well, with as close as benefits that you currently have with Humana. Their rate is coming in at $317.68.
And this is for your voluntary population. Go to the next slide. Okay, this next slide is showing the automatic enrollment. So the member count that would potentially be moving over if there was an automatic enrollment circumstance or outcome, that's 2,731 folks. So we've got that brought all the way over to the right-hand side, and that rate would be $255.17. And you'll see that annual cost of $8 million with a dollar change of 1.3. And then to the right-hand side, that's the same Blue Cross plan with the same population of 352, $4.5 million change there, and that's about an $11.5 million annual cost. Now, on the next slide, we do have some options with Humana to create some out-of-pocket costs with your current population, just to show that differential, to try to get you back down to a flat or create some savings there. But then again, that's increasing out-of-pocket costs to your members. So we did request that. You'll see with $1,000 out-of-pocket max, $10 PCP visit, $20 PCP visit, and then the enhanced $2,000 benefit at the bottom, that would yield around a flat increase for your renewal. And then to the right-hand side, a $1,500 out-of-pocket max, $15 PCP visit copay, a $25 specialist visit copay, a $65 copay for emergency room would yield an $80,000 savings from current. These are just some benchmarkings compared to other school systems. I just kind of wanted to get some of that information in front of you so you can see what other school systems are doing around here in Louisiana. There's certain school systems that are requiring folks to move or doing that mandatory enrollment.
Which ones are they?
So St. Tammany Parish School System requires all Medicare eligibles to move to their Humana Medicare Advantage plan.
East Baton Rouge also requires them.
And
They're with
then,
United Healthcare.
and then Lafayette, they have to move. I believe there are 2 local school districts that just implemented 7-1 that put in place a Medicare Advantage program and put in something very similar to what we're offering with the 1-year stay and the opt-out after year 1.
And we can get you 2 more districts that just moved
I just-
July 1.
I just said that.
Oh, good.
Yep. And we believe, you're going to see this occur more and more year over year because the cost of claims and the cost of medical care. Any questions on those 4 options that we have for you
Can you
today?
talk a little bit about option 4, since we haven't mentioned it?
Oh, yes. Yeah, so option 4 really would be a school system requirement that anyone that's hired as a new hire effective 1/1/2025, and then at some point retires and is Medicare eligible, would have to then at that point pick up Medicare Part B, A and B timely, and enroll into the Medicare Advantage plan. It's a plan document change in your Blue Cross plan. So it's really a statement that would be included in your Blue Cross plan document or contract that states that eligibility requirement and the fact that when that person is Medicare eligible, they would then move to whatever Medicare Advantage retiree program you have in place.
Yeah, and also just to mention that, Mr. Hidalgo, you asked about, Humana and Blue Cross. You can't elect both of those options, but other than that, all of these options can be elected, together. So you could make option 4, you can put that in place. You can put option 3 in place in addition to 1 or 2.
So option 4 just seems like it's a standalone option, because
Yeah.
if option 1, 2, or 3 are adopted, then option 4 is automatic. Yeah, I mean,
Yeah, except
Yeah.
that you are allowing folks to get back on your plan. So if you put option 4 in place, they would not have
what's
that
the
option.
impact to our plan in a 5-year or any window of time more than 1 year if we implement option 4? So if we implemented option 4, what's the impact to our plan within, say, a 2 to 5 year period?
No, I don't believe we've ran those numbers, but it would at least stop it moving forward. We do have concerns here.
Right.
Moving forward, any active member 1125, but on average, LPSS retires about 100 to 150 people per year. On any given year, some years are a little bit higher, but on average, based on that, we would look at if they were a brand new hire. Let's just say I use that same example I used before, St. Landry Parish, 2 years later, I retire with the district. If I'm 65 or older and they process through our department, we pull up their date of hire, and if it says the 1125, then yes, that member would transition. So you're not at the onset going to have large numbers depending on who's coming to the district and who's eligible for retirement. Most of your new hires are going to be younger, but we do have members who retire and are older and are closer to age 65. That percentage between the 100 and 150 is likely lower if I had to just guesstimate it right now.
So, Ms. LaBeouf, and what you're saying is, basically, just because you retire does not mean you're 65 and eligible. You could retire at
Right.
55
Exactly.
and not be
Yes.
eligible for 10 more years.
Therefore,
Exactly.
So
Therefore, have no impact to the plan.
Exactly.
for a
No
long,
positive
it
or
stops the
negative.
bleed eventually.
But at least you are addressing a concern. My opinion is this. I believe it would be a good measure to put in place, just like we discussed earlier that the board approved through the budget process on May 8th, that we mandate members moving forward getting their Medicare A and B. You made that step during the budget process.
Trish, what is the number in a calendar year as far as new hires into this district? And I'm not just referencing teachers, I'm talking about any new hire.
On any given year, just based on Google Doc that we have, 750 members are coming in. On average, staff can correct me if I'm saying any of these numbers incorrect. On average, for retirees, we probably have 100 to 150 processed through the district thereafter. And there's turnover based on resignations, retirement, terminations.
Yeah, that to me is a number that I think that puts it in perspective, that if you're having 700 people every year that you're having to hire, we need to get this process started.
Now, granted, it could be a 22-year-old that's coming on board, and it will be a bit before they hit that age 65. But we do have members, let's just say I'm 55 or 60, I am closer to retirement, that 65 age, where I would have to pick up my Medicare A and B, maybe 5 years further. And then at least you've identified it as a concern, and you're stopping it moving forward.
Okay, and while we're still on this particular item, before we move forward or backward, we've talked about the difference in the Medicare Advantage plans that you guys are proposing here today. Talk about the difference between the Medicare Advantage plan and just pick one of our existing plans. Let's talk about some differences. Let's talk about what the real impacts are let's talk about the impact is for that retiree who last week came in and got off of our plan and went on to the Medicare Advantage plan. What is that retiree seeing differently in their health care options?
I'm going to ask for a favor, and I don't know if I'm going to get it, but Ms. Daphne, who is a retiree, could you come have a comment on that? Would you mind? Just about your experience in particular with Humana, so that you can describe the plan from that perspective. Would you mind accommodating me? Could you just tell me Humana?
All the best.
All right, I'm one of those retirees who did 10 years. Is this on? I'm one of those retirees who did 10 years with Blue Cross because I retired at 55 and then went on Humana. So I've been on it 9 years. It's been fabulous. We have the best Advantage coverage of anything I've looked at. The only thing that concerns me about the changes are the $1,000 deductible, which would be significant since we have no deductible at this time. The fact that those savings to the board are going to be minimal, I would not want that. And honestly, I spent quite a bit of time last night looking at Humana versus Blue Cross. The Blue Cross Advantage is not what we've got now.
I don't mean to necessarily interrupt you, but if you could please limit your comments to the difference between what you had with the Blue Cross plan, because you were not Medicare eligible at the time, versus what you chose to switch over to.
Okay. I'm sorry, I misunderstood the question. All right, so what we had and could have continued with Blue Cross is increased premiums. The biggest difference is we pay no premiums. My husband and I are both former employees. If he were not, I would be paying $49 a month to have the coverage that essentially gives me the same as the Blue Cross coverage now. Our doctors have been the same. We have not lost a single doctor, and he's been on it 12 years. I've been on it 9 years. We have had no problems. In fact, our doctors have told us, do not give this up. My cardiologist said, don't get rid of this. Do not, because it's the best coverage we could possibly have. Is there anything in specific? Out of pocket, zero. We've had major surgeries. My husband had heart surgery, nothing. You leave paying nothing. We have gotten no bills. On top of having no deductible, there's no copay. There is no way that my husband and I would ever go back. None. Now, we would have some concerns if those benefits were changed. But honestly, we've had major procedures. He's had MRIs. We've run the gamut. He recently had complete shoulder replacement. Zero. I mean, it's almost unbelievable in insurance these days. I can't say enough about what we've had. The biggest problem we've had is overcoming information out there that confuses individual plans with our plan. We need more education, and our doctors' offices need more education. I'd be happy to answer any specifics if you have them. Okay.
So I guess the answer to my question is there's no difference in the health care that one receives because of the plan.
That is
Under these-
correct.
Under these passive PPOs, that's correct. In
Under the passive
individual
PPOs, the-
market, it
the
is
group plan.
different. You know, one of the things that we want to do, no matter what you do here, is there's resources at the state level that, that absolutely know the gambit of the offerings in Louisiana, how they've been licensed, are they, what their star rating is, what the rules are. And through our workshops and through our further education, we absolutely are going to bring those people on board to help with this communication issue.
Yeah, I also want to add that these options up on the screen, the Humana options with the increased out-of-pockets, is not one of the options that we are recommending to move to. So we're recommending to stay with the same current benefit design
Correct.
with Humana.
Correct. And with the little amount of, basically no savings, it's not, no. Okay, if there's no other questions on this topic, you guys can please move on. It's time to
Wrap it up.
wrapping it up.
Okay. This slide right here, we're recommending these contract renewals and provisions. These contracts are contracts that the superintendent approves for Lafayette Parish School System, but we wanted to provide this to you guys for transparency. One, from a timing perspective, transparency, and two, just to highlight some additional items we were able to negotiate. Under the ASO Blue Cross contract, we were able to negotiate a $65,000 subsidy that will be sent back to the school system every year. And then in addition to that, and it can be used for different things like technology, wellness, however you want to use those dollars, it will be sent back to the school system, $65,000 a year. The rates are staying the same, so there's no increase to the cost for Blue Cross to administer your claims. And then in addition to that, we were able to negotiate performance guarantees. So things such as processing and paying claims timely, service as it relates to us in Lafayette communicating with our reps at Blue Cross and ensuring that they perform to where they should be performing. We have some parameters in place to hold them accountable, and they will forfeit some of their fees if they don't meet those certain guidelines. Reinsurance, we're still in the process of working through and negotiating that. At this point, we've got a decrease on the table with your stop-loss contract. Reginex renews 1/1/25. There's no fixed cost for this solution. We analyzed the contract. We will be recommending to renew. Pharmacy, ESI, CVS, these are some highlights as to these contracts that we're going through. We are recommending to pull the Blue Cross population under the RX benefits contract. That would save 1.4. And then we have a few other contracts on there, but you can read through it and take note of what those are that we're working with the school system on. All right, these are the components that we spoke about the last few times that we were in this room with you guys, and it was, in our RFP response and things of that nature. What we did was we had a little bit of data from you guys a few months back, or a month or so back, and we estimated certain solutions and cost savings to implement certain solutions. Well, we then validated those numbers, of course, with all of the data that we then had access to. This first solution that we're proposing, it's a surgical center of excellence solution. There is no admin fee for this solution. However, what happens is they take 35% of the savings to implement this solution. What we're proposing is that you move forward with the fully voluntary program. So this is where they're trying to steer folks, if they want to, there's choice, to high quality with better outcome surgeons. Okay? So they work with a concierge folk to identify the surgery need, and then they steer them to the best surgeon for that particular surgery that they need. And I want to highlight, this is voluntary. Nothing would change under your Blue Cross contract. So if your members would choose not to use this program, they don't have to, but they're going to pay an out-of-pocket cost for that. If they use this program, their deductible and coinsurance is waived. And the high deductible, their deductible cannot be waived because it would fail IRS guidelines, but the coinsurance would be waived. Also, the net savings for year one to implement the fully voluntary product would be $200,000. That's the estimated savings by the vendor, Surgery Plus. And that is net savings. So that is, doing the calculation of and taking that 35% of savings out of what they calculated to be your estimated savings. It's, from a disruption standpoint, it's, in our opinion, green, meaning no disruption, because your members still have the choice to use this program or not. They'll get outreach communications, they'll get an ID card, and if they want to call that number and utilize one of those surgeons under that high quality Center of Excellence center, then they'll get incentivized and it'll be taken care of by this program.
I have a question.
Yep.
Who's chosen the doctors in this particular plan?
So these doctors are in this Center of Excellence network. They have chosen to, they have met certain metrics and requirements from Surgery Plus to be allowed in their network. Now, if you scroll to go to the next one. This will help, I think, answer your question. So in Lafayette, there are joint replacement surgeons in this local area. There are spine surgeons that are in this network here. There are other orthopedic surgeons, and then there is the GYN is working through their negotiated contract. But I think it's important, and you'll see, I do mention some of the surgical centers here that are in the network, a few of them. But what they try to do, it's not necessarily focused on a facility. It's focused on the best surgery for the needs of the patient. So they even gave me an example of when you think of spinal surgeries, there's a multitude of different spine surgeries based on the spinal injury or the diagnosis that person might have. There might be a spine surgeon that's better in one of those areas versus the other, even though you hear that. So what they do is they know these surgeons, and they might say, if you want to go to Baton Rouge to have this surgery done, this surgeon is better than possibly the one locally. Now, again, it's voluntary, right? All right, I'm trying to get through to meet your time. I feel like we have 3 minutes. So this is the next solution, the chronic condition management solution that we proposed. We validated it with a reputable chronic condition management company called Tria Health. They focus on the gap between chronic conditions and pharmacy spend from the member, and pharmacy utilization. So what they do is they have their own pharmacists that become a true concierge. How many times do you have a situation and you go fill a prescription, but there's that lack of that concierge service with a pharmacist? That pharmacist doesn't know may not know all of the other medications, or your providers don't know what other medications you're on. So what this program does is it brings that gap it mends the gap. They are able to take a look at your claims data and your pharmacy prescriptions that you're taking. And so they come up with programs to help make sure that some member is taking the right drugs and trying to bend that gap with the chronic conditions that the member might have. We focused on the 15% engagement. I know there is a lot of information here. They do have a financial guarantee in place. I think that's noteworthy. If there's 15% engagement, if you utilized all these programs, the net savings would be $1 million. But there is a cost to this program, which is different than the last program that I mentioned. So the pharmacy program is $4.25 per employee per month. And then the clinical diabetes and blood pressure monitoring programs are required as well. So it's that $274,000 plus who participates in these programs would be your investment. What am I missing? I'm trying to go fast. I know it's a lot of information. If you look on the next page, you'll see where we utilized your claims data for them to come up with their projected savings number. You'll see that 1,106 members have diabetes. And then these other chronic conditions on the right-hand side are those specific conditions. And then under red, you'll see with diabetes. So these are the conditions that they approach through this program. And it's truly just a concierge program to help bring your providers and their pharmacists together.
Yeah, and just remember, we're attacking, it's chronic condition management. So, right now, we have identified about 300 members that have 5 or more chronic conditions, right? So some of your high-cost claimants that just need to have additional resources to help them better manage all of these different, doctors and prescriptions that are coming at them. So the goal of the program is to really target your high-cost claimants that have multiple chronic conditions.
I have a question, probably a dumb question. Why identify with particularly diabetes? Why outline that one of all of them?
So diabetes is one of the most prevalent chronic conditions, and a lot of times what we see in the data is that, a member that has diabetes, they also have other chronic conditions. So there is a correlation between folks with diabetes and other chronic conditions that they may have.
Yeah, and I think their focus is you might have diabetes, and then you might have chronic pain, and you're seeing a different physician for that diagnosis and a different physician for that diagnosis. As you can see, if you have diabetes, the likelihood of you having multiple other conditions is very high and very likely. But what's not happening are these providers aren't talking to each other. They don't understand holistically the patient and what drugs the patient is taking. What this does is bend the gap and helps even the member understand, oh my gosh, you shouldn't be taking that drug because you're taking that drug, and that's very risky for you to take those two drugs together. It's not a formulary change, it's just more of a concierge education and learning the patient holistically.
Yeah, and the vendor does make the outreach back to the provider. So when these things are identified, they engage with the providers and educate them to make them aware of what's happening with the member.
So we do not do anything like this currently?
You do not.
Okay.
Okay, the last item I'm going to focus on is a dependent audit. Right now, you are self-funded. You pay your own claims. You then have a stop-loss contract in place. There are rules under your plan document that you have to follow as it relates to eligibility. So we are proposing a dependent audit to ensure that the folks that you're paying claims on are actually eligible to be covered under your contract. This technically should be done every 5 years, and that's what we recommend to all of our clients. It should be done every 5 years. So what they're saying is the cost of this program would be $26,260. If you bring your finger down to the net savings, that's minus the cost of the program, they're saying if they hit below average marks, they're going to save the plan $594,000. Average, you'll see between $748,000 and 1.05. They have a guarantee in place. You'll see the savings guarantee is 100% ROI, meaning if they don't meet any of these marks, then they will. Then you don't pay the 26.
Can you give me an example of what would be an ineligible dependent?
Yes.
Okay.
So let's say it's not a spouse and it's a girlfriend. Let's say it's a child that's not a legal dependent, a grandchild, possibly.
Miss Mason, it's like, I use Jennifer Wallet Gardner, but if I just went by Jennifer Wallet and I'm still married, but I could still be Jennifer Wallet and be a girlfriend, and I could have been on that plan, and I shouldn't be on that plan. But
So how would they get in the plan in the first place?
we're not saying what we do now and what has done in the past. You got to imagine how many employees we've had that have never left. I've been in the system for 24 years.
Okay.
So it doesn't mean what we're doing now, what wasn't done then. And so, again, I could be married or I could be a boyfriend, girlfriend living in a house and a child, and I'm claiming that child as my own, and it's not, because the child would have a different last name, right? So if I get married and my spouse had a child, we would have the same last name, but if I'm the man that marries a woman, I'm married with a girlfriend, the child might not have the last name as a man, but you would not know because it's your stepchild. It might not be your stepchild. So this audit would allow us to determine who on the plan should be on the plan and not be on the plan.
Okay. I just want to make sure we're not, striking people from the plan, without
No,
good
so,
reason.
So there's a process stated in the back because of time, but they take your plan document, they go through that thoroughly, and then that's how they do the audit. The audit is done, the disruption you'll see at the bottom, I say yellow, because it will require all of your members to upload documentation that proves that you're a legal spouse, or documentation that proves the eligibility, a birth certificate, a marriage certificate, things of that nature. It's a secure site that this company BMI has. They handle the entire process, takes administration out of it. So it's an outside source that determines the audit and comes up with the results. And then at that point, there is notice that ineligible dependent will be terminated at such and such point in time.
All right, so that brings us to kind of the last slide that we have here. This slide is going to incorporate all of the programs and the dollar savings that we talked about today. You'll see two columns on this slide. One is a fiscal year impact, so it's 6 months, so January through June. The other column is an annual number so that you can see by implementing the program on an annual basis what the impact would look like.
I think it's important to note, too, that we actually took 80% of the projected savings. We wanted to even be more conservative, even though there's financial guarantees on some of these items that we're proposing. We even wanted to go more conservative on the savings, so we only used 80%. I just want to make sure y'all understand, if you're reviewing this and you go from this number to what I show from the vendor standpoint, it's going to be slightly different.
Good point, Lena. Yeah, we're conservative on our budget projections. Would y'all like me to go through each one of these, or is there a need for that?
So you're saying on this page 49 is all of your recommended?
These are the options for the board to consider.
Yeah, so we couldn't.
You couldn't do them all.
Yeah, we can't approve the whole sheet.
No, I know.
You can't do 'em all.
So this is why I'm asking these questions. as a committee, we do have to make some recommendations to the board to vote on or to explore. And so you've given us so many different options. I've written down a few that I will make motions on, but how do we need to do this?
So,
Jeremy, Chair?
yeah, thank you so much. No, it's so much that, how about we do this? I'd like to start here. I do not want to see I will not support a recommendation that includes decreasing any type of benefit to anyone. Active, retiree, anyone. So the plans earlier on the actives where the out-of-pocket and all of that was increased.
The high performance network.
Well, I mean, the high performance network is fine, but why do we have to increase the deductible and maximum out-of-pocket?
Well, so there has to be a 20% spread in benefits between tier 1 and tier 2. The way that we worked the plan design is that we did not feel like the district should go backwards in savings, right? So we moved forward to incorporate the changes that you already made effective 1/1 and then created the 20% differential between tier 1 and tier 2.
So in other words, the only way that we could implement that high-performance network would be to either reduce the deductible by going to that network or increase the deductible if they don't go to that network. And because you're in a deficit, we don't think you're in a position where we could say, keep the benefits like you have them right now. And, oh, if you go to this network over here, that's going to give us a discount, you're going to get a lower deductible, lower coinsurance, et cetera, et cetera. That's just too risky where you sit right now. And so what we did is on the coinsurance, the deductible, the out-of-pocket, we did the minimum amount required to get into the program. So in other words, think of it this way too. If we improve the benefits, we'd have to reduce that deductible by 20%, reduce that coinsurance, reduce that out-of-pocket. And when you look at what the increase in the claims are going to be, it doesn't support a change.
So the high performance network on tier 1, let's just say that, I have a procedure that I have to schedule and, whatever. My doctor's not in that tier 1. Or rather is in that tier 1. I'm not getting a better benefit on the high deductible plan.
The plan is saving the money on that, right? So if you're right now, 40-something% of the billed charges are already in the network. They're getting the same benefit, the plan is getting that savings. Let's say I go to Lord's. I'm going to have a higher deductible. But maybe on some of my services, maybe even my primary care physician, I switch to a Lafayette general physician. For your newer employees and for your people who aren't sick, they tend to not care as much.
Correct.
And they eventually migrate in. It's very similar to the retiree benefit that you're recommending that all employees who are hired as of 1/1 have to migrate to the Medicare Advantage program because they don't know any different. It's common. Remember, there weren't deductibles and there weren't coinsurance 20 years ago. It didn't exist. We had hospitalization plans and that was it. And just lastly, one little comment and then I'll be quiet. Some of the last suggestions were what we call population health suggestions. We're talking about a network change because everybody's having to look at these enhanced benefits, as enhanced high-performance networks. The benchmarking that we provided was not for January 1st, 2025, because we don't have all that benchmarking on on what the different school districts are doing. So when we talked about some of that, or if you go back and you look at that, just know that some of that benchmarking, is going to be old because school districts are making, different decisions. But the population health is another way to curtail cost because you're basically looking at practice patterns of physicians and what their outcomes are. That's the new focus. We squeezed all the money out of the networks. We're getting everything on sale, if you will. And now the question is, who are your high-performance physicians? And how are they measured? They're measured by CMS because Medicare has all that data. They know what the infection rates are. They know what the average lengths of stay in the hospital are. It's difficult, you're right. Anytime you go back to that deductible coinsurance or you go back to the premium, it's difficult. But what we are trying to do is migrate people into a higher performance network where we have what seems to be better outcomes at a lower cost.
May I, Jeremy? One thing that I know I don't want to recommend changing is, and I'm sorry I missed the name of the lady who came up. I'm so sorry. I didn't write down your name. Miss Daphne. Okay, thank you. I don't want to change anything that would affect Miss Daphne, who has moved over to the Medicare plans, and I don't want to change anything that would disrupt that. Have you recommended anything that would change that?
So I recommend, do we have things in here that would change that? Yes. So there are line items that would change, Miss Daphne. That would be the Blue Cross Blue Shield Maple Comprehensive. So that last line item there, in kind of orange. So that would be a change to the Medicare Advantage plan from Humana to Blue Cross of Louisiana. So that is on this list.
Yes, but they've already identified that there's a difference. There's a $5.9 million savings versus a $3.4 million savings just because of Blue Cross's lack of track record in the business. And additionally, they've already identified, and I heard you say it, that the Humana plan is a richer plan than the Blue Cross plan.
That, from a benefit perspective, that is correct. And it would,
So-
yes, we're not recommending a plan design or benefit change to the current Humana plan. We did bring the Blue Cross option to the table for you guys to look at. But as you can see, you mentioned the savings differential there and the plan design differential.
Could it be one of those things that we implemented going forward? So if you're already, we wouldn't want to change anything for the current people, but if you enter, no, you can't. Okay.
Can't be both.
Like immediately. Okay.
And why does it have to be either or? Why can't you have two?
Medicare Advantage plans. I would say that that's just a business reason by,
No, but is there a law? Is there something that prevents us from doing such a thing?
I don't believe so.
With the
I don't-
board,
there's
what
no
the board
law.
member is saying is that there are 400 something that she does not want to change there, but moving forward, anyone else, they would be, at least have a Blue Cross Advantage plan that would be available to them also.
So to answer your question, I'm not aware of any laws that would prevent that. More of an underwriting and business decision by the insurers. Not really knowing how to underwrite the rate based on, different populations hitting different plans. We would have to get a revised proposal or request it if it's available. But like I mentioned, I don't know that the carriers will allow you to sit side by side with two Medicare Advantage plans being offered to your population.
And Francis, I mean, it's a great question. Nobody's ever really asked that, right? OGB doesn't have group advantage programs. What they have is individual products, and then they just put them out there, they're approved, and the retirees get to pick. We can go back to underwriting and see if two companies can be offered. I doubt they're going to let it, but
I'm
we can
only
ask.
referencing what Ms. Mason suggested, is
I
that we had
understand.
someone come up and someone that was very pleased with the plan that they're on.
Mm-hmm.
I mean, there's 400 people. We could say moving forward, all right, no one can get on Humana, and if you want to go to Medicare Advantage, here's Blue Cross, okay?
Right, just have
But
two choices.
everyone who is there can stay there. You're not forcing these people to get off of something that they're satisfied with.
I like the idea, but I just don't think the underwriter's going to allow it. But we will, just like we did on every other contract, we will go back and try.
And Ms. Mason, if I could, I mean, she says she likes the idea. I don't. We've been told it's the same network. We've been told it's a richer benefit. And we're being told that there's almost a $3 million difference in savings. So why on earth would we buy the same product for more money? Why on earth would we do that? And it's not even the same product. It's a worse product. So why would we buy a worse product for more money? So, the sooner we can get out of the feel-good mentality, the better we'll be. Now, we haven't, just with all due respect to our current, company, we have this is not the first, second, or third time we've heard this. We've heard this over and over by professionals in the industry. So this is about good quality health care. If anyone's health care is at jeopardy, then, and that includes the actives who keep on getting hit as well. So my concern is, why on earth would we go to something that is not as good of a product and pay more money for it? Why do we keep talking about that? Why do we keep considering that?
Jeremy, let me just clarify. Choice is always a good idea. If we could have a mandatory enrollment, those over 65 go to a Medicare Advantage program, and both were offerings, and maybe the retiree had to pay the difference in the premium for the more expensive product. I'd love that. It gets more and more complicated. I get more and more complicated. But that's an option. And that makes sense. That makes sense, right? Mandatory enrollment. Why do we keep putting a Band-Aid on this? We know it's a good thing. Can we have two companies? I don't know if you're going to be big enough for the underwriters, but we'll see.
We looked at this with our previous consultant. They went back to the carrier. They spoke to Humana in particular. I'll use that one as a reference. And Humana said, no, it's all or nothing. And I had long conversations with them, and I said, you do realize that you're compromising, losing members that are already on there by making that statement. At the time, that was the statement, which ties into what Gallagher just noted and all the other intricacies behind the scenes that tie into that answer. So I would like to see a follow-up on it. My opinion is, if you're asking that question, in particular, based on board direction, if that's where you're going, just so that you can have that answer, I don't think it's possible. Last we looked at it, we got the no, so that you're aware.
I would like to try to make some motions to bring to the bigger board. And I wanted to kind of start with the easy ones. I think that it's clear that we do need to do a dependent audit. I think it's clear that we need to look at the vesting options for going forward savings. Those are the two that really stick out to me. But it's not.
It's not a cost. There's no cost saving, but it is an option.
Isn't it a future cost saving possibly?
Yeah. Mm-hmm. It's not highlighted in here. Yeah,
Right.
on the sheet.
Right. I guess that would be an outside motion that
Yes.
came out of everything that was presented today.
If you choose number 4, you're basically putting in a vesting, if you choose 4.
Correct. Well, no, you can still have people come in just one on their last year and then get their their full benefits. I am really looking at the option 3 and 4 that you recommended. I feel more comfortable with number 4 for sure, and then number 3, I don't know if I can fully recommend it. I feel like it's something that we need to explore a little further. And then I still am so inclined to not change anything for our, current people who have current actives. I mean, out-of-pocket expenses are out-of-pocket expenses, So does anyone have a clear concept? Yes, I mean, I would love your suggestions.
Okay, so let me try and pull up a one-pager here just for a brief moment, because I don't want I believe you mentioned a second ago, number 4, which is combining the
Yes.
high deductible plan with RX benefits. So keep in mind, that's a contract to which we provided transparency on.
Yeah.
Are you looking at line item number 4, Ms. Mason?
No, I was
Oh, you're on
back
page
to
4.
28. What?
Okay,
Yeah,
which
so we're-
number 4 are
we're on the
you referring
retiree
to?
option.
This one,
The retiree options, okay.
page 27.
Okay, so that is, let me put up just a one-pager, just one brief moment, just so I make sure that you guys are making recommendations based on the options available to you, and we're not making recommendations based on contracts, because that's going to land at the superintendent's doorstep. So just real quick, I'm just going to put it up and just give a visual.
And maybe, our friends here at Gallagher could go through and just, is there one page that has every suggestion? Is that the last page?
Yeah, that's 40.
Okay, I'm just not understanding the last page as much.
So while she's pulling that up, if you look at, for example, the increase, right about the first tan line, increase retiree premiums, remove the Medicare discount. That's a annual savings of about 2.7.5 million.
I'm going to go back to the visuals with the cost savings in just a brief moment. I just wanted to put this up just for a second, just to tell you what the requested action by the board insurance committee that we need, so that we can identify that first. So that first table tells you that Gallagher discussed that narrow network with you with regard to Blue Connect. They've also discussed with you the Medicare Advantage with the automatic enrollment, either through Humana or through Blue Cross, with a automatic enrollment with that 1-year option to come back. The third option that they also provided was the Medicare Advantage voluntary Humana. So that's currently what we have. That's up for renewal with the superintendent based on a contract signature. They also discuss premiums, so removing that Medicare discounted premium for Medicare A and B members. My recommendation, my suggestion would be you pair that. If you're not likely to recommend the Medicare Advantage either through the automatic enrollment with Humana or Blue Cross, then a suggestion would be to pair the premiums, the removal of the Medicare discounted premium, with the current voluntary Medicare Advantage plan. That would be a recommendation. You can pick and choose. I'm going to call it like Piccadilly. You can combine several of the things to make a recommendation as a whole. You mentioned the dependent audit a moment ago, Ms. Mason, the surgical COE with the Surgery Plus is an option, and then the chronic conditions management with Tria Health. So they covered everything in that blue table for a recommendation. The gray table at the bottom was provided for transparency. Everything at the top hinges on the bottom. So it's uber important. That's where those contracts are getting ready to expire right now. Our health insurance, our prescription services, our stop loss with regard to our risk. Remember, we have a risk up to $525,000. We don't want to be without a stop loss policy. So that one's super important. Your Medicare Advantage, it's going to depend on what you do under Medicare Advantage for the pharmacy benefits. Okay, and again, open enrollment hinges on everything. We cannot delay past the October 9th board meeting. So I just wanted to put that in perspective. I'm going to step away, let me know if you need me, and then allow you to go through the cost savings measures with Gallagher.
Ms. LaBeouf, can you increase the size a little
Yeah.
bit for the audience to see, please?
Also, is this document attached to our agenda?
No, ma'am, I was going to talk it through. I
Okay.
figured you were going to be at this place.
Is
At
it
the-
possible, Ms. Gardner, to attach this?
Oh, for you
Okay,
to see,
because I think
is what
that
you're
peop-
saying.
Well, I mean, I can see it now
Okay.
but for the public to understand.
It was
some of
more or less an
these-
internal document. I was just going to try
Right.
and talk you through those pieces. I can definitely
I think-
provide it for you.
I think it was an internal document, so, because there was so much in the book to know what was requested, like what needs to happen.
Right, well, this is exactly
Yeah.
what I wanted, and
Yeah.
it's very helpful, and I'm just wondering, could we make it available to the
We
public?
can attach anything
Okay.
to the agenda, but she needed you to just have it condensed so you know what needed to be taken action by the BIC to move forward to implement everything for, because we can't go further than 10-9.
Right.
Ms. Gardner, you have that in your shared folder. Could you perhaps email it to the board members? Okay. So I knew you were going to be at this place. You were going to be confused after hearing everything. You were going to need a summary, so I just tried to put it as an internal document in a table so that you could, I'm a visual learner, so you could physically see it to know what you needed to make a recommendation on. And then again, the gray table at the bottom, that's what we're having internal discussions with the superintendent, but we did disclose that information today for transparency to let you know the options that are listed below that the superintendent will be signing contracts on. But the contracts hinge on the table at the top.
Can you go back to the top table?
Yeah.
Ms. Mason, and Mr. Lejeune, I have kind of bundled this in my own mind into 3 categories. The third category is the easiest, if you will, which would be the bottom 3 items: dependent audit, surgical, COE, and chronic condition management. We could arguably, someone can make a motion to accept the recommendation on those 3 particular items. We can do as many motions as we need to. I do foresee this being at least 3 separate motions, because then next we would have to discuss what we do with our current plan, which some retirees are on, some, so forth and so forth, and ultimately decide if we're going to take any action in regards to the Medicare Advantage plan, and there are several options there. That's why I think we should separate these votes, because if we try to make this an all or nothing, we're not leaving. So
No, I agree. One little point of, sorry to interrupt, the dependent audit, the surgical COE, and the chronic condition management, is that what you were referring to as population health benefits?
Yes, those are, well, population health
Or-
is really the surgical COE
population
and the
health
chronic condition
audits.
management.
Okay.
The dependent audit's obviously just ensuring that you're in compliance with your plan document.
But is it correct to label those 3 as population health? Or not? Or am I
Can we say
confusing
cost
it
savings
completely?
analysis?
What about point solutions or cost saving solutions, additional cost saving solutions?
I think you guys have it labeled as decisions, solutions.
I think, Ms. Mason, are you
Data
asking
drives.
solutions versus without an impact to employees is what you're looking at as those, correct?
Okay. Well, I guess we don't have to come up with a term to group them, but I was just curious if there was.
If you wanted to group them, and their presentation says data drives decision solutions.
Right. These are
Or-
data driven.
Mr. Hidalgo, I'd like to make a piece. I realized that I forgot the data hire 1125 on this table. I noticed that earlier. So that too would be a requested action by the BIC is what I would need. So if you could add that plus sign. Okay.
So can I go ahead and make the easy motion? Okay. All right. I'd like to make a motion to, okay. So first of all, if I make the motion to adopt or just to send it to the board?
Make a recommendation to the full board that they
Adopt these. Okay. All right. Thank you. I'd like to make a motion to recommend to the board to adopt the dependent audit, the surgical COE and the chronic condition management actions or audit. How do we call that?
Solutions?
Data solutions, recommendations.
From Gallagher.
From Gallagher. Thank you.
Okay. I'll second that.
Okay, so the motion is that the Board Insurance Committee recommend to the full board that we adopt the dependent audit, surgical COE, and chronic conditions management recommendations from Gallagher. We have a second. Now it's time for public comment on these three items. If we can free up a mic. And if anyone would like to make public comment on this motion, now is your chance. Low-hanging fruit. Committee members? All right, hearing none, please call for the vote. Unless we don't.
Mr. Hidalgo,
Yes.
Mr. Lejeune,
Yes.
Ms. Mason,
Yes.
3 for, none against.
Motion carries. All right, we're going to continue on this item. And I don't know if anyone wants to take the lead on it, but
Can you put the list up again? It's very helpful.
It's here.
I think she's got it. It's coming. Thank you. Our control booth in the back is busy today.
so committee members, do you guys want to look at actions as it relates to our existing plan regarding the recommendations about Blue Connect, or do you guys want to talk about an action regarding the Medicare Advantage plan and eligible retirees?
I think that the Blue Connect, I don't know, I at least want to bring it to board discussion. I'm not sure if I can fully buy into recommending that we do this, but I think that it should be brought to discussion for the board.
I'm gonna agree. I think the full board needs to be educated on it.
Right, and I think bringing it to the board, helps them, it will make them understand it a little bit better. So, should I go ahead with the motion here? Are you okay with that? Okay. I'd like to make the motion that we bring the narrow network Blue Connect with plan design changes to discussion to the board.
And I'll second that.
Okay, we have a motion and a second. Any public comment on this item? I agree with you guys. I'm concerned about the potential changes. Because it it does precisely what some of it potentially does precisely what some of the the concerned retirees are concerned about. This actually will potentially do that, where you may have to choose another doctor if you don't want to pay the higher out of pocket. So this is a tough one, and I don't think affecting so many people potentially negatively for a $2 million savings is where we should be looking. So I think that let's plan to have some very deliberate, detailed conversations with the board on this particular item. All right. Yes.
The next motion I want to make.
Wait. We got to vote on it, and she still has.
I'm so
Mr.
sorry.
Hidalgo, would you prefer that we come back on 10-2 and hit a reboot on that and bring you some other options? I just asked
I don't know
Gallagher if we
if
could do
we're-
that.
Yeah, I don't know if we're needing other options, but I'll tell you this. When you say to the board, what meeting?
I know. I just realized we don't have. We're going to have another committee meeting before we.
You
You'll have
will.
another
Yes, ma'am.
BIC on October 2nd, and then your next board meeting is October 9th. So this recommendation doesn't even have to be made at this vote doesn't have to be
Okay,
made.
so I'd like to withdraw my motion, please.
But we can bring back, I think Ms. Trish is offering to bring back other options if you would like to see. Is that what you're
I
trying
would
to do?
like to go down that path.
So it sounds like you want options that do not negatively affect the member. Is that what I'm hearing?
Yes.
Can you give me some examples, just so Gallagher can hear?
Well,
Just,
my examples are way down the road, right? Direct negotiations. We've already had one. I've said this before. I'll say it again. We've already had one provider, one entity in this town call us, come sit in our office and say, we want to directly negotiate with you. You are going to get a better deal if you negotiate directly with us. That meeting has already been had by a provider, a major provider in this town, in this parish. So, you know, that's a far down the road. And what I don't want to see us do is continue to increase out-of-pocket maximums, deductibles, and all of the things that do not have a direct correlation with less expensive health care, right? We have some things on this list today that have a direct correlation, fair, equitable, safe, makes sense for better health, for better cost health care. But on the other side, we're just keeping increasing and increasing and increasing. I'd like to see us not do that. So short term, I don't have the answer. But long term, I believe I've given an idea or a couple of them.
okay, we can definitely come back on 10-2 at the next Board Insurance Committee meeting and deliver you some new information, some new options. Okay.
Thank you. Y'all good with that, right? Everybody's happy.
Okay. I would like to make a motion for the fourth recommendation here on page 27 by Gallagher, that all new hires effective 1/1/2025, once they retire and become Medicare eligible, are required to get parts A and B, and it will be mandatory for them to move to the Medicare Advantage plan.
Ms. Christie, that's on page 27, if you need to copy from there.
A motion and a second that all new hires effective 1/1/25, once they retire and become Medicare eligible, are required to get parts A and B and will be mandatory for them to move to the Medicare Advantage plan. Do we have any public comment?
It's not the appropriate time, I'm sure, but it, are we going to get to comment on the plan part itself today, or we have to come back on the second?
More specific, please.
We've had a motion for the bottom three, and we're now having a motion for the new hires, correct?
Yes.
Is there going to be discussion or a motion on any of the others so we can comment today, or will that wait till the second?
Well, we don't know yet. We're not done yet, but I'll tell you that if I'm understanding your question, currently there's no, the part of the motion is keeping the plan the same, just changing the the eligibility for new hires effective 1/1. So I guess we'll have to wait and see if there's another motion. Yes.
This, Ms. Mounts, this motion just referred to a Medicare Advantage plan. It did not name the specific one.
Just a point of clarification, and I did talk to the consultants at the break, and they reassured me, but I'd like it on record because there are a few of us out there in the public watching or will watch the video. Those of us that are not eligible and will never be eligible for Medicare, we will be grandfathered in and stay on Blue Cross. Is that correct?
If it has to do with me, yes.
I think legally.
We're not, we've never even come close to swaying away from that.
But I noticed, like,
the terminology we continuously use is Medicare eligible, and the reason we keep using that terminology is to safeguard folks like yourself who are not, don't have a choice.
And I do appreciate that.
Yes.
I just want a clarification because
Clarification
there's
for-
so few of us.
My vote is yes.
Now, I appreciate that. I need two more.
Is it 112 I think.
Yeah, it's not a big number and we're getting older, but
But you're still
it's really
here.
important to us because we don't have Medicare. This is the only thing we have. And if we had to pay an exorbitant premium, I mean, it would be cost prohibitive for us because, we're older and we worked, some of us, worked at lower salaries. But it's just for a clarification. I noticed in St. Tammany, they use the language grandfathered. And so just a suggestion to protect, there are not a lot of us, but I appreciate that. I really do. And I've noticed you've used Medicare eligible, and I do appreciate that. But I just wanted, because I'm going to get 111 phone calls tonight, and so we just need, I just like it. Thank you. Appreciate it.
I'd like to suggest if another motion is made, that we use that terminology.
Okay.
Grandfather. Okay, any other public comment on the motion on the floor? Committee members, anything else left on this particular item? Great. With that said, call the roll, please.
Mr. Lejeune?
Yes.
Ms. Mason?
Yes.
Mr. Hidalgo?
Yes.
3 for, none against.
Okay, that motion carries. Just been informed that it's 202 members that are not Medicare eligible. All right.
I don't feel comfortable making the recommendation to remove the Medicare discounted premium without understanding what kind of cost or what sort of premiums they would be paying. So, Ms. LaBeouf, for the next insurance meeting, I know that we've done it in the past year, talked about what kind of premiums. If we did remove the Medicare discounted premium.
So,
Ms.
Ms.
Mason,
Mason, if I
Okay,
could
I'm
interrupt
sure
while she
it's
comes
there.
up. It's
Yep.
actually in here.
But do we need to discuss it further?
Yes, and
I think in light of some of the other cost saving things that we're looking at, I mean, does it change that at all?
not asking for a motion, but I think that we should at least identify exactly where it is so that we have plenty of time to look at it. I did glance at it. Some of them are significant. Just the one example was $80 difference. But I'd like to point out that in totality, the annual projected savings for doing this is $2.75 million.
Anyway, it's very significant.
Thank you. Oh, thank you. Okay. Is that what you're needing, Ms. Mason? I'm sorry.
Yes, thank
Okay.
you.
Right, but if they stay.
Again, I go back to, is this going to change? What is the real life change in this for the everyday, doctor's appointment? Are they gonna, can you explain that a little further?
Yes, ma'am. So just keep in mind, Blue Cross processes all the claims. It's totally separate from your premiums. The premiums are managed by the LPSS Insurance and Benefits Department. So it's not going to affect anything one way or another. You're just strictly looking at the premium. We would manage that from an administrative level. Does that help answer your question? So if you're looking, so the most impactful column is 1, 2, 3, 4, 5. The fifth column with the percentages, because that shows you the amount of increase that the retiree is going to experience if you remove that discounted premium.
Ms. Mason, I hate to overstep. The premium decrease is because the retiree is carrying Part B. So as a courtesy, because they were requiring Part B, we decreased the premium. Most districts don't do that. And what we're saying is if we have a level playing field, so like one person a retiree who does not have Medicare Part A or B, who would be paying the $190, the person who is a retiree on Medicare and AB would be covering the $190 also. And so it's leveling the playing field, and that's the cost savings of the 2.6. If this because the retiree also had the option of the $0 plan through the Medicare Advantage.
Okay, so they still have that option
Yes,
for the
ma'am.
0. Okay.
Yes, ma'am. So they still have the option 0 with the increase to the premium. If there's a forced migration in the first year, then the increase is not necessary for the premium because you would not have anyone on A and B who would be needing the increase because they would be paying $0.
Okay.
When you move forward, if after the forced migration, if you choose to come back on the Blue Cross Blue Shield, one of our plans, optional plans, then this rate would be there. So it's not a null vote if you're going to move forward with Medicare Advantage, because if there's a forced migration but the opportunity to come back, then when you come back, you would pay this new premium because you chose to come back. It would still wouldn't be the discounted rate. Does that help
Okay.
explain?
Yes, absolutely. Thank you.
Sorry, Ms.
So,
Buff.
so Ms. Gardner, the majority of the retirees would, in number 3, would get basically an $80 increase.
So currently, yes, sir. So the retiree only. So I know Ms. Landry, you just told us right currently that you do not have A and B. So she would be paying the $190. Correct. She's already paying the $190. But the retiree who does have the A or the B would also pay the $190, which is an $80 increase.
$80
Yes, sir.
increase. Okay.
I think I missed your question altogether, Ms. Mason. I'm
It's
sorry.
okay.
So essentially, Mr. Lejeune, it's that last column that's the most impactful is what it is.
918 retirees would have $80.
Exactly. Yes, sir. You got it.
Yes, sir.
Yes.
That is correct.
Retiree only, of course. You see the other categories. Ms. Mason, options 1 and 2 are either or,
Correct.
and option 3 is kind of
Gives you the
standalone
choice.
because, yeah.
Right. Okay. So I'm going to make a motion to recommend that Medicare eligible retirees with parts A and B who are currently on the group BCBS-LA plan will no longer receive discounted premium for having parts A and B.
Okay. I'll second it.
All right, we have a motion and a second. Do we have any public comment? Yes, ma'am.
Ms. Christie, that's on page 27, number 3, to assist with writing the board doc.
I hope I'm understanding this correctly.
If you could please speak loudly,
Is this better?
it's much better.
Okay, if we could do, is it possible for us to do 3, which Ms. Mason is suggesting, in addition to the voluntary Humana? I don't have the number up there anymore. And in addition to that, the network. Do we have a cost savings for those 3? So doing the number 3 that Ms. Mason suggested, also doing the network, and also doing the voluntary Humana, which we currently have.
The network is 1.85 million. The motion on the floor is 2.75 million. I'm rounding.
Good, great.
And what we've already voted on, we don't know. We don't know.
Got it. I just wanted to say that what we have said from the beginning is that we need to have a choice. The idea of a forced migration, which has happened to some of our neighboring parishes in recent months, and some of them are devastated. I know Mr. Hidalgo doesn't agree that there are doctors who take Medicare but don't take advantage, but Mr. Touchette and Ms. Gardner spent some time with a physician who does just that. And some of these people in adjacent parishes have already had that impact. I don't want that to happen to our teachers.
I'm sorry.
Because this particular doctor is...
Yeah, can
is
we
a-
get
we need,
can we get clarification on that?
We need make sure that that is factual.
You can, Mr. Touchette's sitting right there. He spent the day, or an afternoon, with a physician who takes Medicare and does not take any kind of advantage. It's not
Right, can you-
Humana.
Can you hold on while we verify? I'm so sorry.
What physician is that, Mr. Super?
What was
I
the name?
do not remember I do not remember the physician's name. That is not the takeaway that I got, because the specific question I asked was, if you take Medicare, do you have to take Medicare Advantage? And I was told yes. The concern that I got when we met was more on the prescription side, when it had to do with some of the top tier drugs like Strattera and other drugs.
Yes.
That was the concern. It wasn't the doctor visit. It was more of the drug concern. And actually, in that meeting, I did pull up our formulary for Humana and read the drugs that he called out to confirm that they were eligible. But it wasn't that the doctor wouldn't take the Medicare Advantage. Mr. Touchette, am I correct from the meeting that we had?
Well, the 3 teachers from adjacent parishes have already been turned away from that office, just so you know that. It's already happened. The other
Well,
thing I thought was of significance is that in the last 10 years, if you look at the cost of our insurance in relationship to our total revenue, it has ranged from 1 year at 9%, most years 10 and 11%, 1 year at 12%. This year, with all these changes that we're making, currently, I was just told as an answer to a question that it was 13%. So yes, it's gone up, but 10 years ago, it was just 12%.
So, Ms. Mounts, do you realize the total, see, you're using a percentage, and I appreciate that, and it sounds very insignificant, but 2% on a $500 million budget is not insignificant.
I understand. I understand city and public budgets too well,
Good.
Mr.
Good.
Hidalgo. That is why I asked about the combination of what Ms. Mason recommended, which was the 2.75 savings, I think was one, and 1.85 savings, and you were going to delay the network one till another meeting, the network discussion? I don't think
Yes.
that motion was made.
Yes.
But what was
Yes.
that savings?
That was the 1.85.
And the voluntary Humana? Do we have that number?
Yeah, so here's what we're going to do, because I'm going to honor what I said. We're not going to have questions right now. You can write them down. But if you can send as many questions as you would like, because we are going to have another insurance committee meeting on October the 2nd, which is prior to the drop dead date that the board needs to vote on all of this, which is October the 9th. So if you could get those questions to either myself or to Mrs. LaBeouf, and we will, in an effort to discuss them at the next board insurance committee meeting.
Well, I support what Ms. Mason is doing. I think it's crucially important that we continue with an opportunity for trust. And we do that by giving everyone the choice and not doing any kind of forced migration that has happened elsewhere.
Thank you.
I wanted to echo something that Jeremy said earlier, and the Ms. Mounts mentioned just now. If there is a doctor that is not taking the Medicare or the thing that you're supposed to be reimbursed for, something is going on with their office, and you need to bring it to the doctor's attention. You know, they have staff and employees who run their books for them, and you know, there's some doctors in town that won't have much business anymore if they don't figure out how to take this kind of payment. So, you know, just wanted to point that out.
I think I just want to make a quick disclosure and a reminder at some of the stuff that was at the bottom of the next steps, which I can pull up. The premium increase, while it does deliver an impact to the budget, it is a short-term solution because it's not a fixed cost. If you remember within the presentation, they discussed the IRA, which is the CMS new changes as of 1125. That's a 10-year change horizon. I wanted to double check. 10-year changes from CMS that will be passed down. So this is not going to stop. I just want to make sure that you understand that piece, that even if the board, the BIC and the board approve this and we move forward, we could likely be back at this table again, still having these same discussions, because it may not be enough due to the fact that it will be a short-term solution because it's not a fixed cost. Those claims under medical and under prescription will still be hitting your plan in this example. Whereas any Medicare Advantage plan, they're not hitting the plan. It's hitting the provider that the board chooses for its membership. Either, I'm going to use the examples that we have before us today, either Humana or Blue Cross. So it's a fixed cost that you pay rather than claims and billing increasing through your self-funded health plan. So just a disclaimer.
So I'm not going to veer off of my, typical philosophy. I think everyone understands that. And I'll tell you right now that it's not, we might be back here talking about it. I heard some commentary today that, why are we talking about this again? This never went away, and it's not going to go away until it is fixed. So we cut ourselves, we stick some bandage over it, we never do anything to prep it, we don't clean it, gets infected, guess what? Got to go back and do it again. We keep doing this over and over. And I am going to continue to preach this because we have not made the right decisions in totality. I understand that we all want choice, but I mean, to go back to choice, do we really have choice? Because we have a plan right now, and this is the plan. And you can get on this medical plan, or you can go in the market and buy another one. So how much choice is that? So to suggest that we're taking choice away by giving the same medical benefit to our employees, but doing it the right way and not wasting taxpayer dollars on things that are not going to make a difference in someone's health care is a problem. But it's difficult because it's political, and I've said it and I'll say it again. It's going to be back before us. It's not going anywhere. So, we can keep putting the Band-Aid. I don't want to increase people's premiums. Now, I think this increase in premium is going to be a major driver and a significant amount of people who are going to say, okay, it's time for me to move. And then I will argue with Ms. Daphne, I will argue alongside of Ms. Daphne and others who will ultimately have said, oh my gosh, why in the world haven't I done this? There's some who will never say that, but we know it to be true because I've had the testimony from people in Iberia, Vermilion, all around, who have said, listen, it was difficult because we hate change. But once we changed and we realized, duh, again, I'm not trying to play smarter than anyone. These are the professionals who have come year after year and have told us what needs to be done. So this is not going anywhere. This is not going to end anything other than free up $2.7 million of $13 million we already moved for next year, and then we'll be talking about it again until we can get a real grip on our healthcare plan. And I think that major step on the first vote that we made, because it goes back to, if we have people on our plan who legally shouldn't be, we got to get them off the plan. It's really common sense. So thank you for those statements. I think that we all agree. It's just, when are we going to have what it takes to get it done?
Yes, sir.
And we still have a motion on the floor. Any other board member comment? Call the roll.
What's the motion?
The motion is that.
I can read it. That the Board Insurance Committee bring to the full board the recommendation that Medicare eligible retirees with Parts A and B who are currently on the Group BCB SLA plan will no longer receive discounted premiums for having Parts A and B.
Did you have any other?
No,
did you want to say anything about? Okay.
It's just been a while. It's been a while since we made that motion.
Do we need to add the grandfathered in clause? Is that not really
Not on
applied
this,
here?
not on this one.
Okay, thank you.
But, Ms. LaBeouf, are we making it one effective January 1st, 2025? Please.
Would y'all like for me to reread the motion?
Yes.
That the Board Insurance Committee bring to the full board the recommendation that Medicare-eligible retirees with Parts A and B who are currently on the Group BCB SLA plan will no longer receive discounted premiums for having Parts A and B effective January 1st, 2025.
Call for the vote.
Mr. Lejeune?
Yes.
Ms. Mason? Mr. Hidalgo?
Yes.
3 for, none against, motion carries.
All right. With that said, that's the last item on the agenda. This meeting is
Wait,
adjourned.
no. Can I make one more motion?
You sure can.
Okay.
Meeting is not adjourned.
Sorry. Sorry to speak over you. I might need help. I would like, we can't make motions for the staff to do anything, but we can direct the superintendent, correct? Okay. I'd like to make a motion to direct the superintendent to explore vesting options with the insurance committee, or insurance department, please. As a cost-saving measure in the future.
I'll second it.
Okay. Is there any public comment on that particular motion?
Ms. Christie, it would just be to direct staff to explore vesting opportunities for insurance, for the staff to explore vesting opportunities.
Okay. Thank you.
Ms. Gardner, can we get a couple other parishes in the area what their requirements are?
Yes, sir, we are actually already have that all compiled.
Okay, thank you.
So this has been an ongoing conversation that we've already started working on. So we'll be very prepared for 10-2.
The other side of that conversation has been about being competitive in recruiting. So that's where the challenge has been. But, I mean, it's free for all now.
I think within reason, and maybe at the discretion of the superintendent for special cases.
Yeah, and I think that I understand about the vesting, and by all means, I think it's needed, but we have some hires that we need to have, like math, sped, and some of that is a recruiting tool for us to be able to take people in. So I think if we can put some language in there, so at least we have special populations where there's a critical need, that we're able to entice people to come into this district that way.
No, I agree. And I've actually had several conversations through the years where we've had, Lafayette natives move to Texas and then come back, and then they can't get their years or something.
No, that you're talking about. So it takes a while to get the confirmation of their years for their salary schedule. It's different from insurance.
Right. So
Officer group benefits, right now, it takes 20 years for full vesting. That is not what we are looking at or considering. Most districts are anywhere between 5 to 10 in the surrounding, that you work 5 full years to be eligible for your insurance. But we can come back to the table, but we are talking, I think one of you said within reason, yes,
Right,
and that will
within reason.
absolutely be within reason.
okay. Thank you.
Any public comment on the motion? Okay.
Mr. Hidalgo?
Yes.
Ms. Mason?
Yes.
Mr. Lejeune?
Yes.
3 for, none against, motion passes.
Motion carries. Okay. I apologize. Is there anything else? All right. Meeting is adjourned.